So I'm Nikki Doherty. I'm Director of Place and Partnerships for Derby and Derbyshire ICB. And I work with Penny and also Jim Austin from Derbyshire Community Health Services, leading the Neighbourhood Development Programme. Penny, do you want to introduce yourself?
Hi everybody, my name is Penny, Dr. Penny Blackwell. I'm a GP at Hannisbrook Medical Centre in Wirksworth, so that's in the South Derbyshire Dales. I'm here this afternoon because I've got a surgery this afternoon. And I work with Nikki and Jim as a triumvirate leadership on neighbourhood health and care. So I'm the chair and the clinical director for the for neighbourhood health and care across Derby and Derbyshire. So thank you for having us. We tend to try and mix and match it a bit, don't we, Nikki?
We do, so you'll have to bear with us. It's a dialogue, isn't it? Derbyshire dialogues. I didn't even mean to do that.
You did there.
Start as you go. Right, so we'll move on. Hopefully, my technical skills won't keep on letting me down. So just to start off with, the 10-year plan kind of sets out for us where it wants to go, and that kind of really majored on neighbourhood health services. So it set out 3 key shifts nationally. It's called an NHS 10-year plan, but really it will be an NHS, will be health and care and communities. But the NHS 10-year plan sets out 3 shifts: hospital to community, analog to digital, and treatment to prevention. And you will see the hospital community kind of has a major focus on neighbourhood health services and what it will take to achieve those neighbourhood health services. It will be enabled by a big shift from analog to digital, so more digital tools to help us work better together and to support patients. And then, of course, treatment to prevention. So really shifting from a culture of treatment and focus on ill health to focusing on keeping people well and requiring our support less. There's a second slide in there, and I know these have been sent out. I won't linger on those. There's a whole load of enablers that sit behind there, and you can read those should you be interested. But the big thing for us is this isn't new. So in 2012, the Health and Care Act came out, and in that they talked about the importance of integration and working in multidisciplinary teams and holistic care wrapped around people, largely with a view of all of this kind of preventative stuff. And then what's happened over the years is we've had multiple reviews. So there have been national reviews by people like Claire Fuller, Patricia Hewitt, Lord Darcy most recently, and they always come out and people get very excited by it and say, oh, isn't this neighbourhood thing a really exciting thing for us? We should do that. Actually, all they've said is since 2012, you haven't made as much progress nationally as you probably ought to have done. And for those of you who know, we're just going through a big reform, which probably is pushing us a little bit faster to do what we need to do. But in Derby and Derbyshire, we've actually achieved a lot in spite of all of that. I've only been here for a year, and this is based on years. So when we go and talk to other areas about what we're doing, they will always say you're years ahead of us. So regrettably, Penny can take a lot of credit. I can take very little credit for it other than speaking about it. So we've got the team up model, which we're going to show you a clip about in a moment. We've got a GP model which works around kind of complexity, and we've also got a really good GP system of like relationships across the whole of Derby and Derbyshire. So we've got a mechanism for providing a single GP voice across the whole of the place, which is really something that's quite impressive, and people envy. We've got great end-of-life care and living well. We do various different things where we have designed multidisciplinary teams working around communities to have to make a difference. And what really sets us apart, some of the reason we've made that impact where others haven't, is we have gone for function before form. So we haven't designed the glossy infrastructure, and if you go and look in other places, the kind of the gloss around it is really impressive, but once you start scratching beneath it, you don't find as much substance as you find in Derbyshire. It's meant that people have spent time thinking about what's the right thing to do to really support people and understand what they need, rather than do that rush of we just want to work together and have a service and you'll have 5 minutes. I'm just gonna I'm gonna stop sharing my screen and let Penny share hers because I've
Thank you,
discovered
Nikki.
that I've got no volume.
I will, and I have. I just wanted to be explicit about something that Nikki was saying, which I hope is coming across very strongly. But it's really, what I don't. But because optics are important, aren't they? Nikki is sitting there with an ICB background. I'm sitting here in my GP surgery. But although we come from health backgrounds, or not, Nikki doesn't entirely, and actually I don't entirely, we are also humans really interested in improving health and well-being. So we talk about patients and people interchangeably. This isn't, and as Nikki already said, it's called an NHS plan, but actually we're not thinking about this as just health or only health. This is truly integrating care with health and social care, but much more ambitious than that, making sure that voluntary community faith and social enterprise sector are included and involved and integral, but also that we're trying to work with our communities and have communities driving change, which we will talk about in a little while. But as Nikki says, let me just I hope this is going to work. Let me show you the team up clip that we got. It's about 5 minutes long, and it's been on ITV already. You might have already seen it. So let me share my screen. And I'd like somebody to, in fact, Nikki, you can tell me if you can see that.
I can see your screen.
Super. Let's see.
And Robert.
Let's see if this works.
No volume.
Okay, I can hear volume. So let me just switch. Let me try something else. Can you hear that?
No.
No?
Do you know, Penny, it's always, we should have tried this out before. It was a very exciting idea. I don't know what people think or what your advice, Mark, is. We have got subtitles on it, so we can play it without sound, or we can leave it for people to the links in the presentation that you've shared, so people can watch it separately, and we can just tell you the story.
Yeah, I would suggest not doing the subtitle version. Can you put a link in the chat so people can more easily find it?
Yeah, sure.
And then they'll be able to obviously watch it after, and then we can continue with the presentation.
I'm really sorry, I can hear all of it.
Look, let me put a link in the chat now, and then Penny, if you unshare your screen, and I will reshare my screen and prove how rubbish I am at multitasking. So basically, Robert is he lives in Derby actually, and he had gone abroad working and was an engineer, and he had a workplace fall, and lost the use of his legs completely, and he was in hospital for years, for months. This is why you should watch it, because I'll just exaggerate. He was in hospital for months in America, and then he came back over here and was in Derby Hospital for a very long time as well, and eventually got home, but was unable to kind of move, access anything, wheelchair bound, but just became very, very, very depressed. He was in and out of hospital, in and out of his GP, and nothing was helping him get what he needed. Every time he went to see somebody, he basically had a very short appointment, and they said, well, we'll give you some more pain relief. So he ended up on just a huge amount of medication. And he got to Christmas a couple of years ago and said to his family and to his doctor, I can't live like this, and I won't live like this. And say, therefore, if we can't do anything, I won't be here after Christmas, because
Nikki, I'm just going to have one more go. Simon Harvey, thank you very much. You've just you might have enabled me to do this. I'll
let you have a go at that, and then I'm going to ruin the story, and I won't tell you anymore. I'll wait for a moment.
Give me 1 second.
Common Vera.
Okay.
Well, let me
like I say, we own the life. Common Vera. And as you can see, I don't emotionally grateful. And that's true. Hello, my name's Robert Bell. Basically, I was a builder, engineer, joiner, carpenter. I was basically a master of all trades. Then it was like change of life. I had a real bad accident. Now I'm Robert Bell in a wheelchair.
I'm Dr Ruth Lenihan. I'm the lead GP for the Complex Needs Service.
I'm Vicky and I am the clinical pharmacist.
My name's Jo, I'm a social prescriber with the Complex Needs team.
Hi, I'm Ian Lawrence. I'm a GP by background and I lead on Team Up Derbyshire.
Hi, I'm Dr Neil Mackay. I'm a GP, but for the past few years I've been involved in the clinical strategy of developing Team Up within Derby City.
I think I had 3 or 4 strokes in the space of a week, and basically it means my brain doesn't send signals to parts of the body that normal people do. The main one is my bowels and my waterworks. My brain will not let me go to toilet unless I sit on a normal toilet.
Key thing with Robert was his housing. The house was completely unsuitable to his needs. It wasn't livable for Robert to lead a fulfilling life. Couldn't access the toilet, struggled to get up and down the stairs. When I first met him, he was in bed, couldn't get out of bed at all.
I had 2 options. I had to not eat and drink and starve myself, or use public transport, wheelchair accessible taxis to take me to public toilets. That I did a lot, but this financially, sometimes I couldn't, so I had to go out eating or drinking because I couldn't afford to use the taxi fare.
When I first met Robert, I think it's fair to say he was in quite a dark place, and to see the difference now, he's a different person really, certainly much happier, much more positive, and it's so rewarding to see that.
I got to a place that if nobody stepped in, I even told my own family that if nothing's going to be done for the new year, I'm not going into the new year as I am. I'm going to protect my own life before the new year. I explained that to professionals, thinking if it wasn't for Ruth stepping in and her team, I would 100% be dead now. They gave me my new lease of life.
What we did with Robert after our initial meeting, he became involved with the rest of the complex needs team, so the health and wellbeing coach, the pharmacist and the social prescriber.
As we have an ageing population with increasing health and social needs, the Team Up process was a real opportunity to bring multiple community agencies and multiple services together and try and get us all to work in slightly different ways.
Really what we want to change is so that everybody's focused on the individual they're trying to support, and they do that together.
How do you feel about the medicines? You take quite a lot. My job is to make sure that people are on the right medicines and at the right doses. I wanted to listen to Robert to find out what mattered to him and then work with him so that we could achieve his goals. We wanted to try and minimise the medication that he took, reduce his side effects, but still support him to have good pain control.
Complex needs coming straight away. We're now changed and there's so much improvement. I'm taking probably 10, 15 tablets less a day.
So I just like to get things done, so if I need something doing, I'll find out who the best person to go to is, and I'll try and make it happen what needs to be done.
Living in the old house wasn't any good for Robert and his health, and moving here has made it a lot easier for us as a family. Obviously the stair lift is just amazing, and obviously everything in the house that what Robert needed.
I can have a shower every day, where before people had to lift me in a bath, lift me back out of a bath. Now, on a chair, wheel me in, turn the shower on, wash, out, done. Push me on, push me off.
Yeah.
With the wheels and that, it's like I've got legs again. In this house, I can actually smile again.
This is an amazing thing for Rob to have. He's got more independence that way, rolling on and rolling off, up and downstairs, wherever he needs to be. It was really hard when he first had his accident, being in hospital, coming home, the dark days of Rob not wanting to get out of bed because he couldn't, and moving here, the children have got the dad back again. We're really happy, very happy.
Thanks, Penny. Well done. And thanks, Simon. So that's just one of many stories of our patients who access the Team Up services. Robert actually came and spoke to one of our team meetings in the ICB, because we felt, it's really important for people to understand the benefit of themselves. And we asked him there whether he thought it was worth it from some people will say, well, hang on a minute, that could have been a one GP visiting rather than this team wrapped around, and isn't it more expensive? And he said, it's not just about him and the fact that he's still alive and all the rest of it. The benefit of that is he hardly goes to hospital anymore. In fact, he hardly sees the GP anymore, and the GP almost contacts him more than the other way around. And he talked about the impact and the benefit for his partner, who had become quite depressed and was having her own kind of mental health pathway and treatment, which has stopped, and along with the counselling, which has stopped. And his children were having additional support in school as well, and all of that additional support has stopped just because a team has taken the time to stop the cycle of lots and lots and lots and lots and lots and lots of interventions and get something right for a person and their family.
Also, I was just going to say, there's also another benefit that we never articulate, or we rarely articulate, which is how much joy it brings if you're part of that team delivering those services in a different way. We know that there are some staff within our Team Up teams across Derby and Derbyshire who may not have actually continued to work in wherever they were working, and for lots and lots of reasons, but actually it's invigorated a lot of people's careers, and often played to their value set about how I want to work with my multidisciplinary team and different colleagues in a different way, and has actually reinvigorated a lot of staff members as well. So sorry to butt in, Nikki.
Never apologise, Penny. It's always a helpful addition. So back to sharing screen and the presentation. Basically, we were kind of like, this is really, 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 really good, but we need to be able to scale it up. We need to be able to do more of it for people. It's not perfect everywhere, so you'll still get some areas where it's like it's not working as brilliantly as it could do. You'll also get a lot of feedback that says, but we haven't got enough of it. So whether it be people in the hospital saying, yeah, but why aren't these people being helped by our Team Up service, or people in the community who are saying, if only we have more capacity because we've got more people who could benefit from this. So we know we need to do more. So we took a little bit of time. What exactly is the problem we're trying to solve here? So we've got a disempowered population who we're disempowering. So we do very short interventions, don't give them time to understand what's going on or what matters to them. And increasingly, they have to become dependent on intervention treatment to be okay. Equally, we've got a real difficulty as a system about enabling that local innovation and having oversight of it. So we've been really, really lucky with Team Up that the level of oversight and scrutiny has been quite low. But then it's also taken us more time than we would like to have to demonstrate the benefit of it, because that connection of benefit was lost with the oversight. Equally, we know where we've tried to do something the other way around and has it tightly managed by the system, the level of innovation has been hindered, and you just get more of the same and wonder why things aren't improving. And then we were thinking about how are we going to kind of scale this up? What would we need? And we're kind of like, we haven't got enough scalable accountability framework. So we haven't got a mechanism to be confident that we could do this safely and make sure that we're able to deploy resources in a safe and manageable way through into neighbourhoods. And we also haven't got any infrastructure for managing pooled budgets. And going back to that bit about this is health and care, we want to be able to have something where we can have pooled budgets for our professionals, and able to use that in the most effective way, whether it be with voluntary sector, community resources, social care, or NHS. So technical problems with my thing. Desired outcomes, almost the opposite of that. We want to empower local decision making through scaled collaboration. So although we want to put some scaled architecture in, some scaled solutions so that we can hold money and we can have some kind of assurance mechanisms that allow us to do this, actually, and you'll see in our model in a moment, what we want is decision making to be as close to communities and what communities need as possible. And a little bit more than that, we want to turn things on its head. So we want people and communities to be driving our agenda and what needs to improve and change, rather than national standards and metrics. So things like an A&E waiting time or access to your GP or whatever it is will be important, but actually they'll be good because we got the right thing for the communities to stay well in the first place. It's not about delivering A&E targets or hospital waiting times. They will deliver themselves by getting this right in the first place. Developing a culture of trust and accountability across the system. So quite often we find that the reason we don't take that risk is because we don't really know what the other person does, and well, I'm not sure whether we can let go of that. So we want to change that and kind of say, no, we need to trust people being expert in their areas and trust that if we ask something, it's going to happen. Improved health outcomes with locally tailored delivery, which is kind of what we've been saying. We just want people to be much more well and happy. And then providers and people who are supported, resilient and connected. So from a provider perspective, we need to make sure that our providers are all in a sustainable place and they can run themselves and they're not having to do this cycle of cutting costs because they're working in silos in an impossible thing. So we need our providers to be well functioning and stable. And then from a people perspective, that's both staff and then people in the communities and our patients. So that's about feeling supported to do what you need to do, but also in control. So particularly as a patient, knowing that you have access to the resources to manage your condition well, manage your health well, and know that when you need to escalate it, you can escalate it and get the right response. But largely, we want people to have more autonomy and agency around their health and well-being they have. Penny, do feel free to jump in. I feel like I'm learning a lot as I go through this, and then you're interrupting me less than normal. It's off-putting. I'll let you do this one.
I'm happy to do this. So, I mean, Nikki alluded at the beginning to only having been here for the last year, but actually the pace of change over this last year has been, and Nikki's been instrumental in creating and supporting. And my first few years, I think, working in this space was really about setting up the culture within which we need to work. So my original brief was, Penny, you need to try and get organisations working better together. You haven't got a budget to do this, but it's about how do you work better together? And that's really hard, isn't it? Because organisations come with their own culture, their own legacies, their own histories, their own stories, some of them very dark. But, you know, everybody has a different story, don't they? And you grow up in an organisation. So a lot of the groundwork initially for quite a few years, because culture change takes about 5 years, was doing the hard yards of getting culture and relationships really embedded, and we need to bring those along with us. It's all about distributed leadership, and I'll go on to the next slide in a minute. And it's really having a really positive outlook and strengths-based approach. So asking what's strong rather than what's wrong. So often, and I will talk about health, particularly here in health, we're often quite risk averse, aren't we? You know, you might go into hospital or even in the community, and people are scared about you falling, so you're advised and told, and you have to use whatever mobility aid it is that you're using for fear of falling, for instance. But actually, in the long run, keeping stronger for longer is about exercising the muscles that you need, being brave, maybe, you know, making it safer to fall, for example, you know, and taking some of the risk away from those clinicians or people who are working with that patient or person. So this is absolutely about strengths-based approach and teaming up, which we've started to talk about. Could you pop the next slide on, Nikki?
I most certainly can.
Thank you. And so the distributed leadership or effective system leadership, this is how we've been trying to support our individual leaders who are working in a place-based way or in a neighbourhood way, and also our organisations, to all levels of an organisation, to move into a position where we are, everybody's leading, everybody's you know, leading, it doesn't have to mean from the front, does it? That people become very adaptive and comfortable with chaos, that everything's very person-centred and inclusive and co-productive where we can be. We might talk about the Insights programme later, which is about a community voice. that we are primarily accountable to people and communities. And I think about that of myself as a GP here in Wirksworth. You know, I feel I'm accountable to the people that I serve, the nearly 10,000 people that I serve. It's about being altruistic, long-term, focused on transformation of the whole system, but people as well. And it's to really surface conflicts and be solution focused rather than have them being blockers to, well, we've always worked that way. So some of the real enablers in this space are thinking, what matters to you? And then nothing about me without me type approach. And as Nikki, we've already talked about communities driving change and taking calculated risks. Some people feel worried about that being on that slide, but I'm really keen that that's there, because sometimes without risk you can't progress. And we are talking about calculated risk, and that we see what's strong. So thanks, Nikki. I think it's back to you.
So this is the model, and it will, I suppose it looks a bit weird, but essentially the top layer here is integrated neighbourhood teams, and they are around 30 to 50,000 patient population. And what they do is do delivery. So they deliver care to their population around, you know, so that's the wraparound support. What do we need to do? And it could be anything. It depends on what the support is. So we'll have a number of teams teaming up to support certain groups of people to be able to do whatever they need to do. It already exists a little bit, so primary care networks work on this level, but this is bigger than a primary care network, because this is about not just general practice, this is about all of the different bits of the community and voluntary sector and social care coming together for the right reason. They will have a relationship with what we call hyperlocal bits. So people, you know, the first connection with people, which might be a community like a library, it might be a voluntary sector organisation or a club, it could be the GP practice, the optometrist, whoever it is, pharmacist. And they will be able to connect into that integrated neighbourhood team to secure some of that additional support for those people who would benefit from it. A little bit like we've just seen, well, exactly like we've just seen described for Robert, where his GP said, you know, I think this is what you need. The Neighbourhood Health Alliance level, which is 100 to 250,000 patient population, and we have currently their kind of borough council footprints for Derbyshire and Derby City for Derby. They will be roughly around that. Derby City is just having conversations about what's the best way of organising themselves, because city populations are always a little bit different and they don't naturally form neighbourhoods. And then Derbyshire will likely remain on those borough, even with the local government reorganisation, likely remain on those footprints. They will do the coordinating role. So there'll be some leadership capacity in there, and there will be the ability to hold a delegated budget. Doesn't necessarily, well, in our model, we intend it not to be a separate organisation. We intend it to be within the overall governance of our integrated health and care system. So what we would expect with maturity, so we'll describe what they would need to be able to demonstrate their strengths and capability to be, would be for them ultimately to hold the budget and make decisions with the integrated neighbourhood teams and the population, the communities they're working with, on how best to spend that budget. And that will be to get the best outcomes for people, to keep them as well and as at home for as long as possible, and reduce their need for the hospital care. In my mind, I kind of think if you are able to see at that level what your hospital utilisation is, that's an indication of how successful your other interventions are being, because if you're successful, your population will only need hospital, whether it be planned or unplanned, when they really, really, really need it. And then finally, this whole system, integrated care and support, is like what nationally they're calling an IHO, an integrated healthcare organisation. We're calling it an integrating healthcare organisation, because this level is all about empowerment. It is not there to control. So what Penny was just talking about in terms of the systems leadership stuff, it is not a controlling thing, it's an empowering and enabling thing. It's a thing that goes, what do you need to be able to do this, and how can we help you? And we are not going to control your decisions unless you need additional help or you're struggling. So designing that bit is going to be really tricky, because most of us will know people who gravitate to positions of leadership and power quite often like the power. So we're being very careful to try and describe how we would recruit into these spaces to make sure we're recruiting for people who are able to empower rather than control. And then that's interesting. I've put these in a funny order, haven't I? So what does it mean? I know where I was doing it this way. What does it mean for our Derby and Derbyshire? So what I've just said, and I'm pointing to the screen and you can't see me pointing to it. So I'm pointing at the geographies, the boroughs. So those are the map there. Those are what are currently 8 neighbourhoods. And as I said, we're just talking with Derby City about what that does look or doesn't look like moving forward. We're really keen that we get it right. So in the slide before, we talked about principles. We're ahead because we've spent all of that time developing culture and relationships. So unless there's a good reason to change what we're doing already, we don't want to ask people to change, because it will just set us back a long time. So we're keen to do whatever we can to support people to work together most effectively. And then the integrated neighbourhood teams will be the same number as those primary care networks. So simply put, what's different for patients? We're changing things. We're joining Care at more around local neighbourhoods and the communities that people live in. Care is going to be closer to home. It's not just going to be about care though, is it? It's going to be about well-being. It's going to be able to be much better able to understand how to stay well and access the things that you need to stay well. And then the services, statutory services and other services, will work with you around what matters to you. We've also just had a big conversation, which has been interesting, about how we get better partnered with business and high street partners, because that's a big part of the community and they've got an awful lot to bring and offer. What it means is that I've said a lot of this already, you will be able to access the support more easily. It will be more personalised and joined up, and it will, instead of, I don't know how many people are cycling through the hospital system at the moment, but I have been, and a personal reflection, and one I hear of many other people, is if someone had taken the time to ask what was really going on and a personalised approach, we could have probably solved in 1 month what it's taken 2 years to do. So there's something about really being personalised and joined up in the same way that Robert experienced in his clip as well. And overall, we should all have less need to go to hospital for care. We'll only need to go for it when we really do need that specialised care and everything else isn't working. We are all getting older. There are always going to be things that absolutely need the hospital and the support that the hospital can do, but let's make sure that it's freed up to do what it does well and best. So how can people get involved? Mark set this out at the beginning. Share your experience here, get involved in local events. We're holding neighbourhood events as well. We're always happy to come out and talk to organisations. In fact, that seems to be our main job these days, Penny, but we're really keen to communicate what we're doing and to listen to the feedback. Anybody who heard any of this, some of you may or may not heard some of this in its very early days, and it has significantly changed in the way that we articulate and think about it, not because we got it wrong, but because we were listening, and people have really helped to enhance our thinking. So don't feel shy at sharing your views. We are not sensitive folk, mostly. Just to say, there was a national, and this is out of date now, because when we shared them, we didn't know the outcome on this, but there's been a national neighbourhood implementation programme, which of course we submitted an application for. We'd be crazy not to. Wave 1 was announced and we weren't successful. Now for Derby and Derbyshire, we submitted 1 application because the model we've just described recognises one place, which is Derby and Derbyshire working together. And one of our USPs, it turns out, and I hadn't appreciated how unique this is that in spite of having two local authorities, we actually work very effectively together as one place. So we were really keen that we put it in as one place. And that was how nationally they had just defined it. So what's your local authority NHS footprint for you to agree? Nationally, they couldn't get their heads around that being possible. So they said it's a bit too risky for them, and we haven't gone into wave one. But we will be involved in wave one, both in terms of learning from what they do, and also they've asked us to contribute from our learning, which is interesting. But we will still be focusing around bringing physical and mental health hubs together. So one thing that we've noticed is nationally there's a drive to do physical health hubs in neighbourhoods and mental health hubs in neighbourhoods, slightly described differently. And what we have done in conversation with people is it's not really a difference. It's just a well-being place and one place for people to come to be well. So we're going to look at how we can bring those two programmes of work together to do that. And there are other opportunities that we'll be engaging with as well. And then just finally, next steps. Commissioning intentions is a little bit boring for people, but our intentions for what we commission moving forward will set out what we do. So we're just writing those intentions and they will come out and be consulted on. There'll be a reasonably short time frame because, as always in the NHS, we're a little bit behind, but there will be a time frame to feed back on them. And then what we really want to do, and interested on views on this because it's an intention at the moment rather than an actual, but we want to start as we mean to go on, and we want to start designing the details of our plan through our neighbourhood communities and the people who live in them. So it's an ambition. We haven't done it before. It won't be perfect, but that's what we would like to do. We've been working with the Good Governance Institute on what a governance framework and maturity matrix would look like. And once we've got that, we will be working with people in the neighbourhood alliances and the integrated neighbourhood teams to make sure that we've got everything in place that we need to be able to start making progress on this. That will be, I'm jumping one here, that will be supported by our local Derby and Derbyshire neighbourhood development series. So we will be putting in some additional support, training, space for people to come together and start working out how this is all going to happen. We'll be working with our providers at scale to define what that integrated healthcare organisation bit looks like, and that will be finding the right partner and the right leadership to do that empowerment rather than control, but to be able to hold and offer resources for the neighbourhoods to be successful. And then finally, we're going to have an integrated team overseeing this as a steering group, just to make sure that we are being true to ourselves and making sure this isn't a health treatment thing. It is a whole system improvement and well-being thing. And I think that takes us on to questions. So I'll stop sharing my screen. Have you been clocking the chat, Penny?
Yeah, I have.
I'm on that. I'll control that. Don't worry.
Fantastic.
First of all, thank you very much. That was a great presentation. Really loved it. So the first question from the chat is from Alison. It says, is there risk of different service levels being available in different neighbourhoods, a postcode lottery risk, and how will this be managed?
There is, there is always that risk with everything that we do, and we've got a little bit. We've always had a bit of that. The intention is, so if you in what we've just described said, right, well, let's just wait until people are mature enough to do this, and then we'll go with the people who are more mature and not with the others who are less mature, then yeah, it will be really, really mixed. So one of the reasons we want to get that IHO, that high level bit sorted out, is so that all neighbourhoods, all communities, all integrated neighbourhood teams will have access to the capability to deliver things across the patch from the word go. So people who are less developed will have a higher level of support, and then as their maturity goes, they'll have less support and it will be delivered locally. we do expect there to be some variation, because not every neighbourhood needs the same thing, so it'd be like going to all neighbourhoods and say you need this, and actually some neighbourhoods are just like, that's not a thing for us, but this is a really important thing. So there'll be flexibility to focus on the things that are most important to that neighbourhood, and our outcomes in terms of well-being, etc., and experience will drive that, which is why we want the communities to be able to understand it, and they will be able to compare themselves as well.
So I think that's really important. To add to what Nikki's saying and talking about the flexibility, there's got to be a basics, probably the wrong word, but a minimum level of service, hasn't there, across the whole patch. But as Nikki says, it depends on your demographics. So the Dales, where I am, will have a very different demographic and a very different level of need of different things than you might if you're in one of the areas in Derby City. So we've got to be able to be flexible, adaptable, but also it's reliant on, as I said before, this is about working with the community, for the community. So there will be different community resources that are in different localities and geographies, won't there, that can be utilised differently. So it's about harnessing the power of people and communities to be engaged in these outcomes as well, isn't it? So it's all about it being flexible. As Nikki says, it's all about measuring outcomes rather than saying activity, you need to do this many of this in that area. It's about how do we improve people's outcomes for health and well-being, and it's that's really important.
Thank you for that. There is another one in the chat, but we'll go to Simon Harvey has his hand up. Simon, would you like to ask your question?
Yeah, certainly. And yeah, really interesting presentation. So thanks for taking us through that. And
thanks for helping with the sound.
No, it's all right. Just one of my many skills.
Well, very skilled.
Or haven't made the same mistake many times. So for those who don't know me, I'm Simon Harvey, one of the Assistant Directors of Public Health at Derbyshire County Council. And we're very keen to understand how the neighbourhood model is going to work with all of the changes in the NHS and how we can best support you with that. I guess for me, the questions I've got are, so you've mentioned about prevention and health inequalities sort of being golden threads running through, and I'm sure more detail will emerge. I guess the bits I'm interested and perhaps to expand on is how you anticipate, sort of what you anticipate the prevention, the left shift being in terms of what your sort of some more examples, I guess, because I'm just mindful there are examples for the older end of the population, and I get that, and the need for wraparound care and integrated social care and health. But we've got a cohort of people who are perhaps 15 years younger than that, who in the next 15 years will be in that place, or maybe get there 10 years before that, because we're already seeing some like decline in health at the end of working life. And I guess also just thinking of that prevention, then also some of the life course stuff, because again, we've talked quite heavily about adults. I'm mindful we haven't talked about children and young people in the example, but I'm assuming children and young people will be within that, and especially those transitional ages between children and adult healthcare. And then the last one is just about the inequalities angle. So again, we've talked about communities, neighbourhoods, but I'm mindful some of the inequalities lie with populations who don't fit a particular geography, and just how those inequalities are going to be identified and considered. Again, Michael will support you in all those conversations.
I was going to say, we tackle first. I was going to say, talk about the inequalities is interesting. So the way we've presented the picture, obviously, is that the neighbourhoods are geographically located where it makes sense to be, doesn't it? But that doesn't mean that they're working in isolation, Simon. So that if there are, so the point of having a leadership team across the whole of Derby and Derbyshire would be to have a programme where it enables a connection. So I don't know, Derbyshire Dales and the Arch and Amber Valley might be working on a similar project or a pocket of population that is where health inequalities are similar, or they've got similar problems. So it might have to be delivered differently in different areas, because of whatever resource there is available or locally available, but and appropriate for that population. But it doesn't mean that the work has to be done in isolation, is what I'm saying. We're looking at one of the enablers, I can't remember what the slide said, but it's around business intelligence really, and about how do we equip our neighbourhoods and our PCNs and our communities with an understanding of themselves and where they're working to be able to make the most impact. So that is an area that we're actively pursuing and working on, because the business intelligence is tricky. It's hard to do, but that is something we're doing. Go on.
I think the big bit as well here is there's a big bit for us in local authority and ICB, noting that ICB is changing around strategic commissioning and joint commissioning together, because some of that will be, we're going to have to be quite brave about resource allocation and making sure that how we commission this allows us to direct resources in disproportionately to those areas with greater inequality to become more equal, and really understand where that's going to help and where it's not going to help, what are the things that we need to do. Prevention stuff, I haven't got a more detailed answer for you. The NHS plan has set out some very specific things for prevention, as you would expect it to, around CVD and obesity and smoking. But Penny and I are also massive advocates of the personalisation agenda and social prescribing and getting people well and empowered. So we need to, over the coming weeks, we need to be starting to define what we will do and when. And I think we would want to do that in partnership rather than anything else, and supported where we can by good evidence.
We didn't touch on the children and young people, did we? But that is a thread that we are increasingly pulling on and working with, isn't it, is what I would say. I'm a massive advocate of having education and educational resources within this programme. We're not quite there yet, but that's not lack of desire.
Is it fair to say, Penny, as well, that in the leadership kind of oversight thing, Andy Smith from Derby City is one of the key team, and he particularly, having done his national role as well around the children's agenda, is pushing very hard for us to do something linked into some of the national reform as well, but around children and young people. And of course, schools, the wellbeing, the best start stuff is really huge, and probably one of the areas we're more behind on. So getting a realistic programme of how we can support neighbourhoods to do that. And a lot of this needs to be, we need to move away from a doing to into a doing with, because we need to be giving communities the tools and the support to be able to do this for themselves rather than treating them.
So and it's not just children and young people who are within schools, it's the resource that they can be in supporting the voluntary sector organisations and improving health and wellbeing of other people, isn't it? Really keen. My husband's a head teacher locally, and I think it's a programme that's really important to us, as you say, Nikki. We're also linked in with the locality children's partnerships. So
yeah.
Okay. Next question is, we will come to you, John, but next question is from Karen. It's in the chat. It says, for living well in North East Derbyshire, we really struggle to access rooms to see patients face to face. It would be great to link up with local GPs and surgeries or business partners to access community space to see mutual or local patients. The joint hubs would be amazing for this. Do you have comment for that?
It might not be politic to say this. I don't want an answer to this, but I'm going to say what's stopping you. I'd be quite interested to hear what's stopping you, but perhaps not for this recorded meeting. I'd be very happy to be approached to understand where those blockers are, because it's working those through, isn't it?
John, would you like to ask your question? You have a hand up.
Yeah, actually there's two brief ones. What sort of role do you see for patient participation groups in all these developments, and could they be given support in terms of ideas and proposals and programs that might be arising? That's the first one. And secondly, I have a great interest in the children and young people focus, and I would like, if possible, to discuss with some folks the issue of the very nature of the curriculum that is set out for many youngsters with neurodiverse issues?
PPGs, I could probably talk about a little bit. I think our PPGs across Derby and Derbyshire are probably in the stage of evolution since the pandemic, and there's been new guidance from the National Association of Patient Participation about what a modern PPG might look like, including virtual attendance, virtual support, and really I like to think about it as patient engagement rather than just a one patient participation group. I'm not really answering your question. I don't know the answer. I've not thought about the answer to that. What I would say would be what I would love I'd like my PPG to be much more like a governing body, almost being a critical friend of the practice and supporting and enabling them to really hear the voice of their population would be a really good start. But I need to think about that a bit more. I don't know if you've got anything to add to that, Nikki.
Well, I think in our direction of travel, where we're wanting communities to drive it. So I quite often give an example of we're really good at going out to consultation on something. So, but it's normally based on a problem that we know. So A&E is the obvious one. There's not enough, there's too longer waits at A&E. What are we going to do about it? So we go out and consult, but we've probably already come up with a plan, which probably looks like an urgent treatment centre. And we'll ask for some opinions and we'll say, oh, yes, we're hearing that. And you do want better access. And you know, if only you had your GP and then you wouldn't have needed to go to A&E. So we'll create something in the middle, propose something like an urgent treatment centre, implement it, consult on it, and it all goes, everyone says the same thing. And yet somehow the problem's still there. Because really, what you don't want to do is need your GP or A&E in the first place. And so we're asking the wrong things. So what we really want from our PPGs and our communities, and there will be a number of different ways, including PPGs, that we can get this voice, is what is it that's not happening in your community, that's not there to support you? That means you're finding yourself needing more use of GP or A&E than normal. How can we, what can we do that really changes that around so that it's a healthy community? So I think that's the PPG one. I haven't got a great answer on the neurodiversity bit in schools, other than inclusion is going to be really important, and understanding how to get the best out of people, whether it be in schools, in their communities, or even in our collective workplaces. And we know that doing that means that you can't expect people to be or engage with things in the way that you do. I'm the mum of a neurodiverse child and a stepmom of a neurodiverse child, both very, very different in their needs from the school, both in different schools, both with different support offers, and the impact the impact of the different approaches is really, really stark. And it is as simple as that wrapping around. It's the same thing we talked about in terms of what Team Up does and understanding what matters to you. It is just understanding people's preferences and how to get the best out of them, and working to do that, or supporting them to engage vice versa, the other way around, in how you do things. So I haven't got an answer, but inclusion will be really, really important as a theme across all of our
hugely,
kind of,
it's a big part of
minority groups,
isn't it?
Yeah.
Okay, we have another question. This is from Claire. She asks, how are you planning to reach people in communities to ensure they're driving the neighbourhood work whilst not expecting them to come to you?
So, I mean, some of that is about the, I'd be interested to know if anybody's managed to engage with the Insights programme, which is about hearing community voice, and Health Watch, who are a big part of that, aren't they, Nikki? In terms of hearing the voice of the local communities. And I think there's been lots of drop-ins at various community events that they've been running anyway. So, you know, I know they've been to Chatsworth Fair, for instance. So I know they physically get around, as well as sometimes use GP populations, because I have a registered boundary population, to send out messages or about particular things. I think this will also depend on how the integrated teams deliver their care and support, and how they get hold of that intelligence. It is tricky, isn't it? We don't want to wait for people to come to us, but then we should use every opportunity when they do to think, how can I change this for more people? How do we engage on a wider footprint? So it is tricky. It's probably depends on the local leadership very much.
I'd be a little bit cheeky as well and say I'd want to know from local communities about how to do that best. You know, there's loads of different preferences.
Very much so.
The NHS app is going to do some stuff for us, which will make it easier because that'll be a common way of patients engaging. But what we really want to do is create meaningful connections in communities. So what I'd be really keen to do is find a way of a space where people do want to go to, and because it's a good thing for them, and also use that as a forum to engage with, whether it's a supermarket, a local club, whatever it is. And I think we will not dictate what that looks like, but we will ask the neighbourhoods, integrated neighbourhood teams, to identify a range of different places that we can do that well.
Just to our presenters, we're nearly up to the hour. We have 3 or 4 more questions. Are you okay to field these?
Yeah, sure.
Yes, go for it.
I am.
Brilliant.
I'm just checking.
Okay, so we have a question from Claire. Oh no, we've done Claire's. That's brilliant news. We have a question from Nikki. There is not always the same capacity in VCSE partners delivering commission services as there are in statutory teams. These commission services have a profound impact on well-being, but it is unlikely there will be capacity for full coverage. How will you ensure input from these services and ensure there is sufficient resources for them to hold up their part?
There's a vision on this. Well, they're not even a vision, maybe an ambition, and it's yet to be proven. So the ambition is, you've got these total budgets. Obviously, there's going to be a longer term arrangement. So for our VCSE partners, the funding arrangement should be over a longer period of time, rather than this kind of constant cycling, which will allow some additional capacity to be done. We're trying to also make sure that we are being clear on system engineering, so system outcomes rather than measuring individuals. So instead of each VCSE having to go, what's my value? Actually, it's a system value. You are part of that neighbourhood delivery, and the neighbourhood is measured as a neighbourhood, not as a, you know, you did this bit, you did this bit. And then I suppose linked into that, over time as this develops, and the trick will be difficult here, because what you don't want to do is lose the identity of any of our partners, where identity is important. So maybe some of the statutory stuff we'll be less fussy about if there's a good reason for identity to be lost. But for VCSE, that identity actually is quite important to work at doing this well. So whilst maintaining that identity, also being very much part of that team, that neighbourhood team. And so it's because you're engaging there between you ought to be able to find, it doesn't have to be someone from VCSE, you just need to have confidence that the right messages are being advocated for, and actually your voice is amplified because your partners are advocating the same thing as you would. So that's the ambition. And what we haven't described yet, and we will have to do again together, is what are we going to do or ask of ourselves that holds us to account, so that we don't do the classic thing of slipping into bad habits because everything gets a little bit pressured. We need to be able to be constantly coming back and saying, are we being true to what we intended to do? Are we achieving what we set out to achieve? We're just talking, Newton are doing a community transformation programme with us at the moment, and we're just talking to them about what could we start doing when we're thinking about outcomes, metrics and stuff like that at a neighbourhood level that would hold us to account against our ambition rather than a default A&E target.
Okay,
next question. I was going to say, that sort of speaks to John Spriggs-Taylor's comment in the chat, doesn't it, about holding ourselves to account. We need to be better at doing that and being honest where we need to be. And I think as a whole team, we're very committed to that as a leadership team for neighbourhoods. And talking about inappropriate admissions, that is one of the biggest areas of focus that Team Up has started. That's where we began, not only preventing admissions or attendance, actually preventing attendance at a hospital when it's there's got to be a better and easier alternative for me as a GP on a Friday evening, not to put somebody in ED or to hospital. There's got to be a great local community offer instead when people are not safe to be at home. So there's all of that, and that work's ongoing. But that's exactly where we've started. But also for those who do end up in hospital, ensuring that they have a quick and safe and supported discharge home that gives the clinicians confidence to discharge them, but also the community confidence that they can care for them quickly.
Thank you for looking at John's comment there. There is one final question, then we'll wrap it up, and it's from Juliet. So Juliet says, how are resources going to be shifted into the VCFSE, which is Voluntary Community Faith and Social Enterprise? She says, commissioning really needs an overhaul. We need longer time periods to work in than 1 year or even 6 months as we currently have to operate.
We know.
I think we've just answered that one as well, haven't we? With
yeah.
that is the intention, and it is the whole bit of the IHO stuff, and this is the tension I'm talking about between kind of retaining identity but also benefiting from the system. So that overarching architecture should be able to allow some additional resource from that scalable stuff to be able to be accessed by other bits of the system, including VCSE. So when we're talking about one of the outcomes being providers that are resilient and capable, that includes our VCSE. So there are some contracting mechanisms that we need to do, and how we do that. What we don't want to do, we want to move away from having VCSE as a separate thing that we commission to being very much part of the neighbourhood on a long-term basis. There are very few examples of where that's been done well. So some of this we'll be designing with you together, because what we want to do is say, what do we want to achieve together? What do we need to be able to do that? And then we need to design the commissioning and contracting to make that a reality. One of the things we usually talk about in terms of why have we not been successful historically is that actually nationally and sometimes locally imposed contracts aren't done to aid integration and collaborative working, and they're done just to put a service spec in there, and they kind of drive silo working rather than what we want to achieve. So the contracting and the contracting is the last thing that makes it possible for you to do what you need to do. And we want to really look hard at how do we design all of our enabling bits so that they are enabling rather than disabling. So it's an ambition at this point in time. But I think both of us would absolutely labour. We are not going to answer questions on this by ourselves, even though we like to do it. We are absolutely going to resist the urge to answer the questions and come out and talk to people about what we need to do and how we would do it well.
But there is a real commitment to get recurrent funding as much as we can, and to enabling. Well, one of our ambitions is to make sure that organisations are stable, and that would also include the voluntary community sector. It's a difficult sector to corral, isn't it? Because there's small and large organisations that are doing something on a very hyper-local to on a national scale, but I've absolutely got to get this right, because I know as a GP that a lot of the reasons that people sit in the chair that's here in front of me are coming in for social problems that are causing some sort of medical ill health, or sometimes not even doing that. But there's social problems after social problems, and we can't mend that with prescriptions, can we? We can mend that with social prescriptions, sorry, I should say, but not medical ones, and very often. So this has got to be a sector that we commit to supporting.
Excellent. So let's have one final question. Hopefully it will be super fast. Aaron Johnson, please.
Yeah, thank you. Just more of a comment really for Nikki and Penny. I've spoken with Penny previously, so yeah, Aaron Johnson.
Yeah, hi Aaron.
Hi, Bolsover District Council, partnership lead, strategic partnership lead in health and wellbeing as well. So just coming on to some of your comments around children and young people, around skills and health, and also looking at businesses and how you can engage with businesses. So without going into too much detail, that's how we've structured ourselves as a partnership with all these different thematics We talk about strategic alignment. We've worked really hard to align ourselves strategically to not just yourselves, but other governing bodies as well. Yeah. So how we work is like a top-down and a bottom-up approach, which includes an inclusive commissioning process, which I think, assume is what you're talking about as well there. And we've recently, we've funded for a longer period our voluntary community sector organisation for the exact reasons that you're saying. And I'd very much welcome you, Nikki and Penny, to come along to an exec board, present this,
that'd be great.
Get all that information, and we can hopefully help support you on this approach, because I think it's fantastic and it's very much needed. So well done.
Oh, thanks, Aaron.
That was a great one to end up on, because one of the powers in Derbyshire Dialogue is networking and getting these things going as well. So we'll call that a close. So if anybody else has any other questions or comments, please put them. You can send them to me at dicb.engagement@nhs.net, and I'll ensure that they get answered and sent back to you. So I'd like to thank our two presenters, Penny and Nikki. Apart from the little hiccup with the video, everything was absolutely brilliant. Absolutely loved it, and the video was great as well. Mostly I'd like to thank the audience. Without you we couldn't have these sessions. They're super useful for me. I'm sure they are for you as well. After this session, a recording will be uploaded to our YouTube channel, and I will send out an email to everybody that was here, so you can access the recording, and also with an invite to our next session through our new, easier way of signing up, which you'll also be able to see on there. The next Derbyshire Dialogue session, look forward to, is on the 15th of October and will be winter vaccinations. So thank you very much for your time, and
thank you for having us.